Resistant hypertension in chronic kidney patients. My name is Mike Spigler, and I'm the Vice President of Patient Support and Education for the American Kidney Fund, and I'll be serving as your moderator for today's session. Before we get started, I'd like to thank our sponsors, AstraZeneca and Boehringer Ingelheim, for their support of this session. You may not know that many people struggle with high blood pressure that can't be controlled, despite being on several different medicines. Doctors often call this resistant hypertension, and it is common in people with chronic kidney disease. It can also be a warning sign of a person being at increased chance for heart and blood vessel issues. Today, we will have a conversation discussing resistant hypertension, how it affects CKD patients, challenges in managing it, and new and developing treatment. But before we get started, I want to introduce our two esteemed guest speakers. First is Dr. Swapnil Hiramath. Dr. Hiramath is a staff nephrologist at the Ottawa Hospital, a professor in the Faculty of Medicine at the University of Ottawa, and also an associate scientist in the clinical epidemiology program at the Ottawa Hospital Research Institute. He attained his medical education at the University of Mumbai and at the University of Ottawa. He has a master's in public health from Harvard University and holds a certification from the American Heart Association as a specialist in clinical hypertension. His primary research interest is in using knowledge synthesis with hypertension and patients with acute kidney injury. He has authored more than 200 papers and is also the co-creator of the online nephrology journal club and podcast, NephJC. Next is Dr. Cohen. Dr. Jordy Cohen is an associate professor of medicine and epidemiology in the Renal, Electrolyte, and Hypertension Division at the University of Pennsylvania. Her research examines physiology-driven pharmacological effects of antihypertensive medications in high-risk patients. She is chair of the American Heart Association's Hypertension Science Committee and is also co-chair of the American Medical Association's Blood Pressure Validated Device Listing. Thank you very much, Swap and Jordy, as well as you, the audience, for joining us as we hold this very important conversation discussing the connection between cardiovascular disease and kidney health. Before we jump in, I want to encourage everyone joining to please type your questions and comments into the chat box on the right. We will do our very best to get to all of your questions during the question and answer segment at the end of this webinar. So I'm going to jump in, but I want to start off by asking both of you to tell us a little bit about your particular areas of interest, the research you're involved in, and Swap, I'm going to start with you. What are your areas of interest, and how did you develop an interest in high blood pressure management?
Thanks again for having me here. I'm really excited for this discussion with, on a topic very close to my heart. High blood pressure and kidneys, as we have mentioned already, go together very, very closely. We use high blood pressure lowering drugs every day in the patients who have kidney disease. Funnily enough, my research interest was more in hemodialysis and things like that, and I fell into hypertension because we do have a large hypertension clinic. At different centers, different doctors treat hypertension, but somehow in Ottawa, it's the kidney doctors, the nephrologists who treat hypertension. And we have a large clinic. One of my colleagues suggested I should get involved, and that's how I got involved about 15 years ago now, and I haven't looked back. It's been a fun journey. Most of my research is around high blood pressure, in particular resistant hypertension, as well as looking at lifestyle measures like, not just sodium, but potassium and BP lowering.
Great. Well, Jordy, obviously, hearing your bio, you also have a great interest in high blood pressure. Could you tell us a little bit about your current roles and just start with giving the audience a little bit of an introduction to what do we even mean by high blood pressure?
Yeah, so a little bit about myself. I mostly see patients in a complex hypertension clinic that's been certified by the American Heart Association to focus in people who have really difficult to manage high blood pressure. My research is specifically involved in trying to find the right blood pressure medication for the right patients, especially people who have a lot of other diseases that make the high blood pressure maybe a little bit more challenging to manage. I first got interested in high blood pressure as a kid, actually, because my dad was a primary care doctor and used to come home all the time complaining that he would get all of these patients that would have their hypertension misdiagnosed in one way or another because their blood pressure had been measured incorrectly. And so he made sure that I knew how to check a perfect blood pressure with a mercury device, which are no longer available, but are perfectly accurate devices at the age of 6. So it's in my blood. And I fell in love with nephrology because the kidney is sort of the source of all of the physiology that causes high blood pressure. So high blood pressure is when there's too much pressure or force that builds up in your blood vessels that pushes against the wall of your blood vessels or arteries as your blood is flowing through your body. And that can cause damage over time. It can harm particular organs that are sensitive to it, including your heart, including your kidneys, and including your brain. And this is why we're so concerned about making sure that we really carefully manage high blood pressure to prevent that damage.
Great. Thank you so much. So, we know the Kidney Fund is always vocal about saying that anyone can get kidney disease, but of course, some people have a higher chance because of one or more risk factors. And historically, high blood pressure has been recognized as one of the leading risk factors for kidney disease in the US. But high blood pressure is also caused by kidney disease. So it's really kind of like a chicken and the egg scenario. Swap, I wonder if I come to you to maybe briefly explain the connection between high blood pressure and chronic kidney disease. And for those listening, how do they know if they're dealing with the chicken or the egg?
Exactly right. You took the words out of my mouth. I was going to say chicken and the egg issue. It is truly difficult to tease that out. Historically, we have always said that high blood pressure is a cause of kidney disease. Research in the last 10 years, 20 years in particular, question that. But nevertheless, they are frequent travelers, right? People who have kidney disease do have a high blood pressure, and people who have high blood pressure, as Jody mentioned, especially for many years, often develop kidney disease, and it makes things worse, right? So it is harder to control each other when you have these two conditions which are going together. So with kidney disease, one of the things that the kidneys work on is they get rid of salt, not just water, but salt, right? The urine contains a lot of salt. And if your kidney is not working well, it's not getting rid of that salt that's remaining in your system. That contributes to high blood pressure. As the kidney function goes down, it gets harder to get rid of these things. So that is the main reason why these two things go together. But as far as the cause is concerned, there are many different nuances about how you would think about it, right? So we see in studies that people who have high blood pressure do develop kidney function that goes downhill faster. On the other hand, lowering that blood pressure doesn't necessarily lower the risk of kidney disease. We do know that lowering blood pressure reduces risk of stroke and heart failure, and those are the two big reasons, and of course, dying of heart disease. So those are the main reasons we do treat blood pressure, and these conditions are extremely common in patients who have kidney disease, right? So, to me, it doesn't matter, does lowering blood pressure lower kidney disease or not? It doesn't matter, it lowers heart disease, it lowers stroke, which is so very common in people who are living with kidney disease. Hence, we should lower that. At the same time, the same medicines that lower blood pressure, like ACE inhibitors, angiotensin receptor blockers, SGLT2 inhibitors, they also lower risk of kidney failure, right? So, to me, it's a question of, it doesn't matter whether high blood pressure causes kidney disease or not. It's something we should really be focusing on, because lowering blood pressure in people with kidney disease is really, really important to prevent many other downstream consequences.
Thank you so much. Jordy, let me ask you a question about blood pressure measurement. You mentioned the mercury device that's not around anymore. I mean, it really is so dependent on how it's done. I mean, I know when I go to my dentist, it's great that they take my blood pressure, but my feet are up. It's a wrist machine. I'm sitting in the dentist chair, so obviously my blood pressure is up already. What does it mean to have your blood pressure measured correctly in kidney disease patients? And what does it mean for providers? What should they be doing?
Yeah, it's incredibly important to get an accurate blood pressure, because any kind of incorrect steps that are taken in measuring a blood pressure can cause your blood pressure to be quite significantly higher or lower than what your true blood pressure is, and can result in either over or under treatment of hypertension if those numbers are being used to inform changes in blood pressure medication or addition of blood pressure medication. And so it's incredibly important to get them very accurate. As much as a difference of even something like 5 millimeters of mercury, the difference in points that we look at can really reclassify someone's blood pressure and impact whether or not they're having new medications added or taken away. So I think it's incredibly important that we do an accurate job of measuring blood pressure. But generally and broadly, people don't do a great job. I think people who are measuring their blood pressure at home often learn from people in the office who are not following all the necessary steps to check blood pressure. And it creates this cycle of getting inaccurate blood pressures. So there are a few things that are incredibly important to keep in mind. The first one is making sure that the device is actually accurate. These blood pressure devices that are manual are no longer mercury devices, which were the perfectly accurate devices. Now there's something called aneroid devices. Aneroid devices, the new manual devices, are really, really, really prone to losing their accuracy. As soon as someone knocks against them, all the calibration inside of them can get thrown off. So those devices really are no longer what we're recommending in our guidelines for people to use to check blood pressure because they're not usually maintained well, even though a lot of clinicians still rely on using those. So the first step is using an automated device because they tend to be, in most people, more accurate as long as they've been tested appropriately for accuracy. There are international standards that have to be adhered to for these to be checked for accuracy. There are a few online listings of which devices are accurate, and it's really important both for clinicians and for you as patients at home to make sure that the device that you're using is accurate. So an example of a listing for devices available in the United States is the American Medical Association's validated device listing. I'm co-chair of the group that volunteer to review these devices to make sure that they're actually accurate, and that is at www.validatebp.org. And then there's also an international one that's stridebp.org. And we all have different levels of rigor. There's also one in Canada for Hypertension Canada that Swapnil's a part of. Great. So that's first and foremost, that's very important. And next, it's following the right steps to measure blood pressure. Just very briefly, things that often go wrong in the doctor's office that you've mentioned is making sure that it's an upper arm cuff unless you have a reason that you can't check your blood pressure accurately on an upper arm. Making sure the cuff size is right. Larger people need larger cuff sizes, and not all cuff sizes can accommodate that. So it's very, very important to make sure that the cuff fits comfortably and appropriately based off of what the instructions for the device say. You have to be in a quiet room, sitting for at least 3 to 5 minutes before checking your blood pressure, and in the right position. The position really matters a lot. So as somebody who's 5'4" and who is never going to have my feet touch the ground from an exam table, getting your blood pressure checked on an exam table is the worst place because your feet are dangling, your back's not supported. It should be supported. Arm is often hanging by your side, even though it should be supported about at the level of your heart. Also really important to have a bare arm, not to be wearing clothing underneath the cuff. Lots of things that often go wrong. Not be having a conversation while the blood pressure is being checked, and making sure that that your bladder is empty, ideally, which we always do in kidney clinic.
Great. I didn't know that last part at all. I just learned something from you just now myself. So that's great. What are some of the challenges in diagnosing high blood pressure? How can that affect these patients? I mean, obviously in kidney disease, 9 out of 10 people with kidney disease don't know they have it. What does the misdiagnosis kind of rates or the undiagnosis rates look like in high blood pressure, and what can we do about it?
So I can go first, and Jordy can chime in on that. So it's not one of the most common issues we face in people who come to us with high blood pressure is that measurement aspect, right? So you may think, patients who are coming into the hypertension clinic, especially a referral clinic, may have some weird, some rare disease, something that makes their BP hard to control. Lo and behold, we measure it properly. About 1 in 10, sometimes even 1 in 5 people have perfectly fine blood pressure. So that misdiagnosis of somebody whose BP is actually well controlled, but it's thought to be not controlled is very common. Just proper measurement, right? If there is one lesson you can take from today's session is that make sure the BP is properly measured. I know Jordy's covered this again, but I don't measure blood pressure in my clinic because I may not be good at measuring blood pressure. Doctors are terrible at measuring blood pressures in general, though some of them may be better than others. We have nurses who spend a lot of time measuring blood pressure and teaching people how actually BP should be measured. And that's what I rely on. So someone who really knows what they're doing should be doing that. Apart from that, some common things that happen with patients who have high blood pressure is that despite how much ever we talk about it, lifestyle factors do matter. It's something we talk about often is the high salt intake. It's easy for me to say, don't eat salt. Don't eat, and by salt, I refer to sodium. Yeah? So there is sodium and potassium. Potassium is present in fruits and vegetables. That actually lowers blood pressure, and that's good. Sodium is present in, all the other processed food in particular. But people think, hey, I'm not eating, a pizza every day. I'm not eating potato chips. But there is sodium in bread, for example, right? So every food, anything that you buy in a box, in a pack, contains a lot of sodium. And that's one of the biggest causes of high blood pressure. This is something, though, that is easy to say, but hard to fix, right? Unless you change your lifestyle completely, you start baking your own bread, you start cooking food from scratch, which are in our busy lives, it's hard. That is one of the big factors why people have high blood pressure, right? So taking care of those aspects, again, they are not very glamorous. They are not very exciting. I'm not talking about, some fancy method and some new medication. But these simple basic stuff is what we pay attention to initially. And that takes care of a large proportion of patients who have high blood pressure. Jody, would you add something to that?
The only thing that I would add too is you'd mentioned all the treatment artifact. I think that I did want to briefly touch on, all the measurement artifact about mismeasuring blood pressure. I did want to touch on white coat hypertension and masked hypertension. I think people are really familiar with the term white coat hypertension, which is when your blood pressure is elevated only in the doctor's office, but normal at home. And that happens a lot, as Swapnil is getting at, due to that mismeasurement, but it also can just be some people just don't like being in the doctor's office, or just your brain misfires when you're in the doctor's office and it makes your blood pressure go a bit higher. And that's not associated with higher long-term risk, and that isn't really something that should be treated, which is part of why it's so important to be getting accurate blood pressures out of the office. Also, about 1 in 4 people with kidney disease may have something called masked hypertension, which is when your blood pressure is often normal in the doctor's office, but high outside of the doctor's office all the time, which is where you spend most of your time. And that's part of why it's so important for people with kidney disease in particular, who are more susceptible to this than many other people, to be checking blood pressures at home using appropriate technique and an accurate device.
Thank you, Jordy. So Swap, you talked about some of the things that are, diet and some other things that you could do. And let's say someone is doing that, they're on some of the common medications, but they're still not getting, a normal reading or a controlled reading. Can you just describe it? Is that what resistant high blood pressure is that we're talking about today? And are there certain things that can cause that to happen?
Exactly. So, resistant is something that is not coming down, right? So resistant as a, term means blood pressure that is not coming under control. But for reasons of classification and guidelines, we like to have a certain definition. So typically this is blood pressure which is not at target. Different organizations use different numbers, but let's say it's still higher than 130 over 80, despite 3 BP lowering drugs which are given at optimal or maximum tolerated doses. So 3, again, the reason there is a definition is because if someone's blood pressure is not controlled with 3 medications at optimal doses, then that should trigger certain things, right? Maybe it triggers a referral to someone like me or Jordy, or it triggers certain investigations, right? So plain vanilla hypertension, which is treated with 1 or 2 pills, doesn't necessarily need to be seen by a specialist. But people whose BP is higher and not controlled despite 3 medications, that's when you want to look at other things. When you want to look at, hey, are we missing a diagnosis? Are we missing a cause for high blood pressure? There may be issues with your hormones. With the aldosterone gland is a very common thing, or chronic kidney disease in particular. Maybe people have narrowing in the kidney arteries. There are these specific causes that need specific treatment that we should be thinking of. Now, with respect to those 3 drugs, we just say 3 drugs. We don't necessarily specify which 3 drugs. But the commonest drugs that should be used as first line are drugs that actually have been shown not only to lower blood pressure, but also to lower, what we talked about. The reason we treat high blood pressure is because it's a risk factor for, bad things like stroke, kidney disease, heart disease, and so on and so forth. So we talk about calcium channel blockers. So for example, amlodipine is one of them. We talk about ACE inhibitors or ARBs. So drugs like, losartan, candesartan, olmesartan, perindopril, things like that, and a thiazide diuretic, so hydrochlorothiazide or chlorthalidone or indapamide. So we like drugs from these 3 classes to be given. And often what we find is when patients come to us, they may be on 3 drugs, but they may be on something really not appropriate, like hydralazine or beta blockers, like metoprolol. And those drugs they lower the number, but they are not what we like to be first line. So those are the kind of things we look at. And try to fix to make sure they are on the right pills in the right combinations. So certain combinations make sense physiologically and pharmacologically, and that's sort of where we go.
Well, we certainly have lots of kidney patients that are here listening to this as well. I'd maybe pose this to either one of you, both of you, if you want to give an answer to this. I mean, what is the different kind of considerations for a patient with kidney disease and treating high blood pressure? And are there different considerations as someone starts, from CKD stage 1 all the way down to stage 5 and even on dialysis? How does that kind of perspective change? I don't know who wants to maybe answer that one first.
Yeah, I'll get started on that. There's a lot to unpack there that's really important to talk about. First and foremost, those 3 main classes apply to everybody. Anybody with high blood pressure should ideally be on an ACE inhibitor or an ARB. the sartans or the iprils, like what Swapnil was mentioning, a thiazide or thiazide-like diuretic like HCTZ or hydrochlorothiazide or other similar gentle diuretics, and a calcium channel blocker like amlodipine or nifedipine. The one thing that's really important is that that applies at any stage of kidney disease, and a lot of people get misinformation either from online or sometimes from even well-meaning doctors or clinicians who may not know better, that in people with kidney disease they should not be on some of these drugs because they may quote unquote harm the kidney, but that's not true. A lot of these drugs, when we start them, we may see that the kidney function looks worse on labs, but it's because these drugs are actually working to protect your kidney and are just unmasking basically some kidney disease that's already there, but that shows itself when we get blood pressure under control because the kidneys were being overpressured by too much blood flowing through them, making the function maybe look a little better than it truly was. So it's really, really important to make sure that you're touching base with somebody like a nephrologist or a primary care doctor who's really comfortable in managing high blood pressure and kidney disease patients and doesn't steer you in the direction of not being on drugs that are really important to be on. That said, there are certain times with people with kidney disease where some of these drugs can't be used. One example is that there are some people with kidney disease that really struggle with high potassium levels, especially as kidney disease gets much worse. There are medications now that can help to lower potassium levels and can allow you to be on these really protective medications that are very important for protecting your heart in particular, and in many people, the kidneys too. But some people either don't tolerate those potassium drugs or will do anything to not have to be on an extra pill. And so as a result, people end up getting taken off of particularly ACE inhibitors and ARBs often as they get closer to reaching dialysis, because that's when it gets harder and harder to manage potassium. That said, those drugs are really, really helpful in a lot of those patients, particularly in preventing heart disease and major heart events like having heart failure or a heart attack. And there are increasing studies showing it's safe to stay on those drugs long term and to try to use other medications to lower potassium if possible to protect the heart. It's not always possible. Sometimes it's just really hard to do that. But in as many people as we can, we really try to keep people on those main 3 basic drugs because they are just so beneficial. One thing that's really important also that we think about in managing people with chronic kidney disease who have high blood pressure, which is the vast majority of people with kidney disease, is that a lot of high blood pressure and kidney disease is driven by extra fluid in our bodies. Even if we don't see swelling necessarily, kidney disease causes us to retain extra salt, which Swapnil was talking about earlier. That then drives a lot of our hypertension, and it means that we're sort of hiding extra fluid in our body and in our blood vessels that we can really benefit a lot from getting out of our bodies. So most people with chronic kidney disease do benefit more from using extra diuretics or medications that are water pills that make you urinate a bit more to help to try to control blood pressure, even more so than people without kidney disease. And so a lot of our blood pressure management in kidney disease patients really hinges on those medications. Another reason why it's so important to be seeing a clinician who's really familiar with managing high blood pressure in people with kidney disease, because that's sort of an important point that's not always common knowledge.
Swap, anything to add?
Yeah, so just to reiterate, what Jody said, once you go into the advanced kidney disease, right, you mentioned dialysis also. So once you go into situations where the GFR is less than 30, like stage 4 chronic kidney disease or worse, these problems become even more difficult, right? So the side effects that Jody mentioned, high potassium levels, or sometimes you give a chlorthalidone, which is a water pill, you can get low potassium levels or low sodium levels. It doesn't mean that these drugs do not work. They do work. It's just that you have to have a sense of the side effects and tackle those side effects as they happen. So it just becomes a little bit more tricky to manage as the kidney disease worsens. Dialysis itself, though, is a completely different cup of tea, right? So water pills may not work because someone may not even be making any urine. Mostly in dialysis in particular, it's salt retention, right? So getting that salt off with longer dialysis or more frequent dialysis, which is difficult, right? We can't expect patients to be tied to the machine forever, but that really helps. The more amount of salt we get, the lower the blood pressure is. And the last thing I would mention with dialysis is that how you measure it becomes even more important. Imagine getting your, forget the dentist chair. Imagine, you're getting ready for dialysis with a with a fistula needle coming your way and someone's measuring your blood pressure and scolding you about, your 2 or 3 kilowatt weight gain since the last dialysis, that's really not an ideal circumstance to get that resting, quiet blood pressure, right? So we do blood pressure measurements in the dialysis because it's a vital sign. We want to know what is going on with your blood pressure, because if it falls, we take too much fluid off or something may be happening. So that's the reason we measure blood pressure. We don't measure blood pressure in the dialysis unit because it's a target for lowering blood pressure. So the white coat effect, is huge with dialysis patients. So in those patients, it's really, really useful to do what Jody mentioned earlier, is to either get home blood pressures or to get an ambulatory blood pressure monitoring. So those are what we believe. Again, we don't have good trials in dialysis, but we believe it's the numbers that we get at home that we should be looking at rather than the numbers we get in the dialysis unit for treatment. And salt and volume is the biggest issue in dialysis patients for causing high blood pressure.
Thank you very much. Swap, let me ask you this question too. Jordy mentioned the importance of seeing a doctor that, understands this and how to treat high blood pressure. How do you know that you have a doctor that can do that understands what they need to do to try to deal with this? Is it the type of doctor you're seeing? Is it the right kind of questions that you're asking? I certainly invite either to answer, but Swap, I'll start with you.
Yeah, it's a good question, and it is not always easy. So even among my again, I'm not going to name names, but even among nephrologists, among kidney doctors, not everybody is comfortable treating high blood pressure, right? We are, Jody and I do this a lot, so we are way more comfortable at managing hypertension. So it may be that you are seeing a nephrologist, but they may not be necessarily the right person to manage your high blood pressure. So it has to be someone who is comfortable managing high blood pressure. And in some places, it may be, an internal medicine physician. You may have a really good family physician who's good at treating blood pressure. So it's not just the specialty that is important. It's how comfortable your doctor is at managing blood pressure. And you need to have the right connection with them when they are talking about blood pressure. Again, beyond that, it is really hard to say how you can pick and choose people. Even in my case, sometimes, there are issues where an endocrinologist, someone who deals with those hormones may make more sense for particularly vexing issues. So we may even refer patients to someone like that.
Great. Jordy, anything to add?
Nothing to add. I just think advocating for yourself is also really important. And that's why I think collecting this information and being comfortable with understanding how your clinician should be thinking about managing your blood pressure can really help you advocate for yourself, and collecting really accurate and trustworthy home blood pressures to help guide that management.
Well, I have a question for that in just a second. But speaking of questions, I do want to remind the audience that, we will take questions the last 15 minutes. So please continue to put in your comments and questions in the right-hand side. My team will get those over to us, and we'll save some time at the end to answer those questions. Jordy, you just mentioned tracking at home. We talked about the devices, how to find the right device. How often should someone be tracking it? What does that look like at home? Time of day, those kinds of things.
Yeah, great question. And so there's a little bit of disagreement among clinicians, but I like to do what the data supports. And so the best data we have really support checking your blood pressure at home, at least 2 back-to-back readings every time you check. Really, really important. So it should never just be one reading, because it's really common for a lot of people's blood pressure to drop quite a bit after the first reading. Not in everybody, but many people have something that's called an alerting reflex, where that first blood pressure check just sort of stimulates you a little bit and makes your blood pressure go a little bit higher than what it would normally be the rest of the time. So it's useful to always get 2 in everybody, just to make sure that first reading isn't capturing that, or isn't capturing that you were just running around and maybe just haven't had enough of a rest period yet. So always at least 2 readings. Some devices automatically collect 3 readings, which is even better. We typically, based again off of precedents from research studies that are most linked with long-term risk of heart disease, in particular and stroke, we typically recommend checking those 2 blood pressure readings back to back in the morning before taking your blood pressure medication after getting up. This should be before having any coffee. It should be before really eating anything, because some people, when they eat like a big meal in particular, it can make your blood pressure actually suddenly go lower. So we really like it to be when you first wake up before taking medication, because we really want to see if your blood pressure medication that you took from the day before are still sticking around, because really good blood pressure medications really should reach a steady state, which means that they're sort of long acting, they're around in your system, and they're working all the time as long as you're taking them consistently. And if they're not working in the morning, then that's telling us that that maybe you need some more blood pressure medication, or maybe you're having a bigger surge in blood pressure in the morning that would require us to target that a bit better. Then we also recommend getting 2 back-to-back readings in the evening, because this gives us a very different picture of sort of where your blood pressure medications are working later in the day. You've had your full day, you've had all of the stresses that have maybe affected your day, and now you're resting and sitting before bed. Again, it should be at least an hour after having any meal. A good time is to do it right before going to bed. And it should be before taking any evening medications, though. So if that could be impacted by timing, that's, of course, more important to just make sure you take it before evening meds. And so that's really critical in terms of the timing. In terms of the frequency, in people who have pretty high blood pressure or on a lot of medications, we usually recommend doing about a week's worth of readings. The minimum number that you can do is 3 days. We typically suggest doing it in a row, so you get really used to doing it, so your body's in the groove of doing it, and you can get sort of more reliable, consistent readings. And so at least 3 days, ideally 5 to 7 days, but the minimum needed is 3 days, and we realize it can be a big burden to check that often. And typically the suggestion is to do it once a month if you're sort of actively on treatment that could be getting changed. Once you're in really steady and stable, have really steady and stable blood pressures, you can do it a bit less frequently.
Thank you so much. Well, Swap, it already sounds like it's very difficult to manage chronic kidney disease and high blood pressure together. So let's complicate it even more and talk about diabetes and how that affects things as well. The American Heart Association has described the cardio-kidney metabolic disorder. Could you maybe talk a little bit about that and how all three are interplayed?
Yeah, so this is the CKM is this new entity that it's somewhat artificial, but it just recognizes that these conditions often go together, right? So it's not just heart disease, but it's diabetes, it's kidney disease, and even if it's not just over diabetes, often it's being overweight and the things that go together, high cholesterol levels, obesity, sleep apnea. There are all these conditions that are they're travelers together. And we should not be thinking necessarily in isolation, right? In medicine, often we have these silos. I'm a kidney doctor, I'm treating kidney disease. I'm a diabetes doctor, I'm treating diabetes, and I'm a cardiologist, I'm treating just the heart. But really, we are all in the same. Our patients are in the same boat. They're having these conditions together, and that's sort of this purpose of trying to make sure we talk to each other and we are collaborating and we are treating these conditions together. The other reason why this has been brought together is that forever we did not have much that we could use to slow down, especially for our purposes, the progression of kidney disease, but also in heart failure with say there are different kinds of heart failure, but there are certain kinds of heart failure for which we did not have many treatments. Now we do, right? There are these wonderful drugs called SGLT2 inhibitors, so flozins, the canagliflozin, dapagliflozin, empagliflozin, which actually reduce the risk of kidney failure and they reduce the risk of heart failure. There are very few drugs that are like that. Even statins don't do reduce kidney failure. There are also these newer upcoming classes of drugs called GLP-1 receptor antagonists. So Ozempic or Mounjaro are the brand names which are famous, but semaglutide and tirzepatide, and there are many more in the works. These drugs are wonderful. They actually reduce the risk of heart failure. They reduce risk of kidney failure. And part of the purpose is that, they reduce, and they are often diabetes drugs. They started off being diabetes drugs. And we found that they are not just diabetes drugs. They actually help prevent kidney failure. They prevent heart failure. So those kind of things. So, it took us 10, 20 years to get, ACE inhibitors, ARBs, which we have the evidence in early 2000s to get up to speed to using them. I think we should, it's up to us to try to ramp up the use of these new drugs because they are not only do they lower numbers, they actually reduce risk of bad things down the road. So it's really important to do that. And how it comes together with high blood pressure is that these flozins, for example, they reduce blood sugar, but they also reduce blood pressure, especially in people who have high blood sugars by about, depends 5 millimeters, sometimes even up to 10 millimeters. Similarly, the GLP-1 receptor agonists like, semaglutide or tirzepatide, they also reduce, not only do they reduce weight, they are very popular because they reduce weight, but they reduce blood sugars, but they also, again, in people who lose weight, blood pressure also comes down. I have some patients who on these pills, on these injections, who have lost like 20 pounds, and I'm stopping their BP drugs because their BP is so well controlled now.
That's great. That's great, great, great. It's really amazing the different options for patients that exist. I think I shared with you in some of the pre-calls. I started in this field in the early 2000s, and seeing where we are now is just really, really amazing. Jordy, a question for you. I had one more question for each of you, and then I'm going to go to audience questions because we're getting some really great ones in the chat. You talked about advocating for yourself, right? And we talked about some of the factors, white coat syndrome, et cetera, that can affect someone's blood pressure, but there are environmental things too, right? I mean, just life stressors, right? How do those things affect blood pressure, and how do you recommend someone having a conversation, with their doctor about how that may be playing into hypertension?
Yeah, so that's a really great point. We have a lot of research that's shown this, that what's called allostatic load, the effect of all of the stresses around people's lives, especially in certain groups of people that are particularly susceptible to that in terms of their environment, can have a substantial impact on high blood pressure. There was a really good study that came out a few years ago from the cardio cohort, which was this long-term cohort of people that were first assessed when they were pretty young adults and then followed through more middle age, that they found that people who grew up in a really highly deprived neighborhood, meaning a neighborhood that was very, very low income, that maybe didn't have access to a lot of great opportunities and was probably exposed to a lot of stressors surrounding safety, surrounding other factors like insufficient income and food insecurity. And that all of those factors, if somebody stayed in a place like that long term, they were much, 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 much higher risk of developing high blood pressure and heart disease. Whereas if you moved out of a place like that to somewhere that had just the neighborhood itself, a better environment, that you were less likely to develop hypertension. And so there's a lot to be said for that really our environment can just have such a big impact on our risk. I think it's really worth bringing up with your clinician, and this is part of what we talked about with making sure you have a good relationship and trust the person you're working with, because a lot of clinicians can refer you to resources that are available for food insecurity, to social workers that can try to help with some of these factors, because that honestly is going to be a huge component of treating your high blood pressure. Additionally, a couple of other factors related to that. We often underestimate how much just stress and anxiety and depression can affect blood pressure too. And so one of the conversations that I often have early on with a lot of people who come to see me in my hypertension clinic is to try to understand that if anyone's ever really talked to them about how well controlled their stress and anxiety and depression may be, and if they haven't had that conversation yet with their primary care doctor, I at least try to provide an opportunity to offer support either through therapy or through treatment with medication to help with that, because that's actually been shown to help with lowering blood pressure too. And I think that it can really help multiple factors to treat the right target rather than treating somebody's anxiety and depression that's causing high blood pressure with a blood pressure medication that may not do the job. So I think there's a lot to unpack, but those are just a few ideas of ways to think about that. One other thing is also being able to afford medications. Your doctors do have access to ways to help with identifying better sources for less expensive medications, can take into consideration an ability to access medications due to lack of adequate insurance to cover medications, because a lot of the medications that we talked about that are really the most important for treating blood pressure in particular are pennies and should not be expensive. And if they are expensive, it's usually coming from sort of the side of the pharmacy or some interaction between pharmacy and insurance that results in that is not appropriate. And it's really often quite feasible for us to find much less expensive options.
Thank you, Jordy. And just to pitch 2 AKF programs as well, if you're a patient that's on dialysis or have received a kidney transplant, we do have a safety net program that patients can apply for. It's a once a year small grant, but it's something to maybe get you over the hill with over the hump with a copay that you may have. And also right on our homepage, you can find our community resource finder where you can put in your zip code and find lots of different financial and support resources where in your local community as well. And all of that is free and available on the kidneyfund.org website. Swap, one more question to you before we open to audience questions. We talked about sodium and salt control, obviously medication classes. Anything else that can be used kind of in the toolbox to treat resistant high blood pressure?
Yeah, so a couple of things are coming to mind. So one that has actually been approved last year is the renal denervation. So This is a device. So, it's an invasive procedure. So there's a catheter that goes in through the groin, goes to the kidney, and actually zaps the nerves around the arteries that go to the kidney. This can lower blood pressure by about 4 to 7, maybe up to 10 millimeters mercury, which is nothing to sneeze at. There have been some ups and downs in developing the technology. About 10 years ago, we thought it would lower, by 20, 30 millimeters. I think the true effect is closer to 5 to 10 millimeters. So that is, for some patients, that is a choice that is available now. The only thing to keep in mind is that the reason, I'm not saying, hey, let's just, stop pills, go around, this is a cure for hypertension, is because it is not a cure, right? It lowers BP by about 5 millimeters, which is sort of like one pill, which is, again, it's important. Taking less pills is always useful, but it's not like a cure. It's not that, hey, we found a cause for high blood pressure and we are curing it, which can happen in some cases, like someone has an aldosterone problem. We take out the adrenal gland and the BP is cured. This is not like that, right? It does improve BP control. And the second thing with that renal denervation is that it is not, the response is not predictable. So someone may get a 10 millimeter lowering and someone may get 0, right? So on the average, it is 5. And I can't tell you beforehand that the patient that I have in front of me will necessarily have that response. But again, it's an option, right? It's not just about, I'm just not saying just take one more pill, second pill, third pill, fourth pill. There are other options that are available, and we should be exploring everything and discussing this with patients. For this, especially, it's important that you are assessed by someone like Jordi or me in a hypertension setting, right? Don't just go for denervation as a cure. We have to make sure we are not missing any other cause of high blood pressure before we go down that path. There are also many other new medicines that are coming that are still under development, but there are some the promising ones are like there's an injection you can take every 6 months, which controls blood pressure. So again, they are not available yet, but there's a lot of excitement. There are a lot of new therapies that are coming down the pipeline that we'll have in the next few years.
Thank you so much. Well, you guys both shared really, really great information. And for those that you're watching, we do have more resources on our Kidney Action Week website as well to find out more on this and the topic. And I'm sure my team has probably been dropping resources in the chat as we've gone along as well. So we will now open it up to questions. Please continue to enter your questions and comments. We'll get to as many of them as we can here up to about 5 till, and then we'll close. The first question, and I'll open this to whoever wants to take this. For someone who has high blood pressure pretty much all times except during dialysis, where it drops so low that the person has to stop dialysis, is there anything that can be done there?
So do you want me to start, or go ahead, Swapnil? You're the dialysis nerd.
So in fact, what Jordi does is one of her, I think, shifts, if I'm not wrong, is where they do long dialysis at night. And that sort of is possibly a solution to that kind of a problem. So what's happening here is that if that blood pressure is high outside dialysis, that means they truly do have high blood pressure. But often what happens during dialysis is that, during the 3 hours of dialysis, or hopefully longer, like 4 hours, we are trying to remove those 2-3 kilos in that short period of time, right? And your body may or may not tolerate that rapid removal, which is why the blood pressure plummets. There are things we can do by adjusting what blood pressure lowering drugs they take and what time they take them. You don't want to give them, amlodipine just before they go on dialysis, for example. But also what is really important is to reduce volume, so reduce salt consumption to reduce how much it has to be removed on dialysis. But also, if possible, is to have longer or more frequent dialysis, which again, I understand that is not an easy thing to do. But really what sounds like is an issue here is the duration of dialysis. Jordi, would you add something to that?
Yeah, and so just to add a little bit to what Swapnil was saying, so I had a dialysis shift that I led for many years that's still here. I just no longer lead it. That is people who go to dialysis overnight for 8 hours. And it was actually developed specifically for that issue, for people whose blood pressure really plummets when they get fluid removed, because you need to remove fluid essentially at a slower rate to be able to get it off, to prevent your blood pressure from going down so fast. And so, as Swapnil mentioned, ideally it's extending the treatment, but a lot of centers don't have the capacity to handle that. Sometimes they can help you get an extra treatment, which can also help, as what Swapnil mentioned, so you can get the fluid removed at each treatment at a lower rate to help prevent that from occurring. The other thing that I did want to mention, though, is sometimes it's also due to medical issues. So a lot of people who were on my shift were people who had medical reasons that unfortunately were really hard to address that caused it, such as really advanced liver disease can cause this issue, though typically your blood pressure wouldn't be high the rest of the time, so it's probably not that in your case. Or also there are some heart conditions that can cause this. Like for instance, a heart valve narrowing can do this. So if you haven't had an echocardiogram, good idea to ask your doctor if you may need one. Most people on dialysis have had them pretty recently, but not always. But also that could also make it harder, and there may not be an easy solution.
Thank you very much, Jordy. And maybe if I could ask my team for the type of dialysis Jordy mentioned, you ever heard of that before? It's nocturnal hemodialysis, and we can put a link to different kinds of dialysis.
Yep.
In the link.
And peritoneal dialysis is another great option for this type
Absolutely.
of situation because it's low and slow. So if you're a candidate for it, I know a lot of people get really intimidated by peritoneal dialysis because it's the idea of having to do things yourself. But it's something that I've had so many people that were intimidated by it that overcame that barrier and really, really did great on it. It gives you more independence. It does a lower and slower and more gentle dialysis that prevents that low blood pressure.
Absolutely. And I know Dawn Edwards, who was the speaker right before this, is a big proponent of home dialysis options, including peritoneal dialysis. And, she's a board member of the Home Dialyzers United, which has got some great information on that too, if you're interested. Well, we're in a hypertension session, but we're getting hypotension questions. But we, for someone not on dialysis, someone that's chronic kidney disease and is dealing with low blood pressure in earlier stages, any advice or thoughts for patients in that situation?
So firstly, of course, make sure you're not on a blood pressure lowering drug, right? So this is something we often are challenged with. For example, someone has, protein leakage in the urine. So we typically try to reduce that by giving drugs like ACE inhibitors or ARBs, the Prils or the Statins. Now we may be giving that to lower the protein leakage, but unfortunately they also lower blood pressure, and that particular patient may or may not need it for blood pressure reasons. This just makes it a little bit more challenging. So that is, again, it may seem like a simple thing, but make sure there are drugs that you may not think are blood pressure lowering drugs, but you may be on. But beyond that, you have to make sure there is not something else that is going on, right? There are other, for example, heart issues, as Jordy mentioned, liver issues that can also lower blood pressure, or hormonal issues, endocrine issues, which can lower blood pressure. So you really need evaluation to make sure there is not some other diagnosis that is causing low blood pressure, which is being missed.
Great. For someone that wants to, you mentioned weight loss swap. Either one of you can answer this question, but and how that can help as well. For someone that wants to start doing more physical activity to try to lose weight, but they already have high blood pressure, any considerations there as they start an activity?
You want to go, Jordy?
I think that except for very extreme circumstances, exercise is usually good. During exercise, your blood pressure does go up. So for my patients who are like extremely heavy weightlifters who have really severe high blood pressure, specifically, I guess some young men I've had who've had aortic dissection, which is where your blood vessels can tear because of extra stress, I recommend not doing extremely heavy weightlifting. Anything else usually is more helpful than harmful, because after you exercise, your blood pressure actually reacts by going down and staying down the more you exercise. And so if anything, it's usually only a good thing, not a bad thing, unless you're really having signs of very sudden heart issues or like stroke-like symptoms from high blood pressure, then it's not a good idea. But as long as you're not having negative symptoms from doing it, it's a great idea to exercise despite having very high blood pressures.
Jordy, to that point, actually, there's probably something to tell the audience as well. What are some of those symptoms for like stroke-like symptoms that people should be prepared for?
The things we really worry about with really dangerous high blood pressure is if people are having issues with slurred speech or sudden weakness in part of your body, or things not making sense, or not being able to talk in a way that makes sense. Very severe sudden headache, severe sudden confusion, severe sudden visual changes. And heart attack type symptoms such as chest pressure, feeling like something's sitting on your chest, left-sided, particularly chest pain, though it can be in other places. Some people will get really severe nausea and vomiting as their presentation with a heart attack. So just something that seems very severe, worrying, and new to you, it's reasonable to pause and ask for help. And then also with kidney issues, we really, related to high blood pressure, it's more a really sudden decrease in urination, or new red urine or tea-colored urine.
Great, thank you very much. Swap, a question for you. We've talked chronic kidney disease patients. We've talked those on dialysis. What about transplant recipients? How common is high blood pressure in transplant recipients? Any special considerations there?
It's extremely common. Really good question. So in transplant recipients, high blood pressure is practically universal. Almost everyone has high blood pressure. So that's partly because, they do have kidney disease. Despite the kidney working, the function is not, completely normal. But more importantly, we give these medicines to prevent rejection. Typically, something like cyclosporin or tacrolimus and steroids. These drugs actually cause high blood pressure. So the reason, the treatment for your transplant includes pills which actually cause high blood pressure. So it's not at all uncommon that most transplant recipients would require some blood pressure lowering drugs. And the considerations there are, we try to use drugs which are easy on the kidney. So typically, one of the most commonly classes of drugs are those calcium channel blockers, the amlodipine or nifedipine, which are used because they sort of help, especially with the high blood pressure, which is because of tacrolimus or cyclosporin, which is causing high blood pressure. But any other class of drugs is also beneficial. The three classes that we mentioned are useful in transplant, and the newer classes of drugs also, will soon be more broadly used in kidney transplant settings.
Great. Well, we're just about out of time, but I'm going to ask each of you just one key takeaway that you want the audience to maybe leave with. And Jordy, I'll start with you.
Empower yourself. Know your blood pressures. Do it correctly so you can trust them and your clinician can trust them. And come with the information to be able to ask the really, really good questions so you can challenge your clinicians to do their best.
Thank you, Jordy. Swap?
Yeah, so measurement, right? Really, really, again, this may be duplication, but measuring blood pressure is so important. And secondly, people don't like taking pills and they think, we are pushing pills, but really the pills that we use not only lower blood pressure, but they decrease the risk of heart disease, kidney disease, stroke. So, be open to taking medications.
Great. Well, on behalf of AKF, and I'm sure all of those that are listening today, I want to thank you both very, very much for your participation, your direction today, and our audience for some great questions as well. Thank you for sending those during this session. I hope you learned as much as I did during this. Coming up next, our next session, our last session of Kidney Action Week today is you'll have the opportunity to learn more about life after receiving a kidney transplant. Just heard some of the blood pressure considerations there, but recognizing that this is a new kind of change that you're dealing with and how to set realistic expectations. Once we conclude this session today, you will see a link for a quick survey in the chat to the right. Please take a minute to fill it out. Tell us how we did. Your feedback is used every year to make the next year's sessions even better, and it's very useful to us. Thanks, everyone. Have a great day.
Our journey with Henry began before he was born. We were caught completely off guard when they said there's a problem with his kidneys. He was born in kidney failure. It was very isolating for us as a family. For him, Henry was not a typical baby. Talking to my friends about typical baby stuff, their advice wouldn't work for Henry. We didn't have a kidney community of people that were going through what we were going through.
I wanted a child for so long, and I just always knew I was going to have a little boy. When we met with the neonatologist, he told us his kidneys do not develop and he will need a transplant.
It was very surreal. I could only pick up on certain keywords. What do you mean, one kidney, next steps, and dialysis and transplant? And that's when it started getting like, wait, what?
In that moment when they said, we're admitting you, I said, okay. I stopped working from that moment on. When he came home, we just really tried to find other people that we could connect with.
Our daughter Kendall was diagnosed with E. coli that turned into HUS back in June of 2023. But unfortunately, a few months ago, they did officially diagnose her with chronic kidney disease. We are just in the beginning stages of how this is going to affect her. My mental health definitely took a hit. The unknown was the most painful thing to go through. Just the uncertainty, not knowing if we were going to be taking her home. She suffered a lot in the hospital. Just hugging her, brushing her hair, taking those little moments and making sure that we treasured them. It is really important to get her connected to a community, not only her, but for me too, to have some outlet that has access to information.
It's so important for our children and ourselves to have authentic friendships. Finding a community where they're accepted is really important.
Virtual camp is definitely a break for her. Just a time to kind of forget about going to the doctor or the hospital.
I found another one.
We're still at the beginning of the journey, so I'm so blessed to have found this early on.
We've done magic and painting and
The bracelets and the airplanes. We'll come home and that box will be at the front doorstep and Zion just lights up.
When that package comes, it's very exciting. It's addressed to Henry, which is special because most of the packages that he gets are medical supplies.
She will pick it up, even if it's heavy. She will pick it up all by herself. She loves doing the projects that we do, but she does love seeing the other kids and talking to them.
I enjoy it because there's a good range of ages in there too. Different areas, different cultures, different backgrounds, boys and girls, and some of the siblings are involved.
there's just this fun anticipation, right? I mean, to have any activity, and it's specialized for him, and it's high quality, amazing, super cool stuff.
This camp has allowed me as a parent to connect with other parents and share some of the challenges that we face, and also share in the joys that we face as well.
It represents another outlet of information and people that you can rely on that have walked through the same thing that you're walking through.
There's also a Facebook group with the parents. We are building a sense of community as virtually as we can, and we get to share our journeys together.
It's so important to have American Kidney Fund. Yeah, I'm so thankful that they have a virtual camp, and it's something that you can log into anywhere.
It's a special time that we can be as a family and just say, okay, let's stop what we're doing. We have a solid hour of just spending some time together.
Camp has been so important for that virtual community, and then also it's spilled over to in-person. I can't even put a price on it. He's growing socially, he's making friends, he's having fun. Camp is part of our life, and it's not just for Henry, I think it's for all of us.